Hi, in this video, we'll continue with chapter 20, and we talked about the autorhythmic fibers. Remember, these are the ones starting from your SA node, and it sends out the action potential and through eventually reaching your contractile fibers. So your contractile fibers really are your cardiac muscles, and they are in the same place as your myocardium. So in this diagram, you can see several. Some are superficial muscles, some are deep muscle of the bundle in the ventricles as well as in the atria. Now, before we go even more deeper into how your heart pumps, I want to refresh your memory also on membrane potential, okay, because this is quite important. Let's orient our cell first. This is outside the cell, and this is inside your cells. Now remember, we have a very important pump that sets up the membrane potential. Do you remember what it was? It's the sodium potassium ATPase pump. So this pump will actually move 3 of the sodium from inside the cell and pump them outside each time. They uses the energy from ATP and to break it down into the ADP and the inorganic phosphate. So also they will move 2 potassium from outside of the cell into the cell. Okay, so you will move it out inside. So eventually, imagine you have 3,000 or more of these pumps. Okay, so if we have tons of it, let's imagine if you have 1,000 of these pumps. So how many, for instance, sodium ions are you going to have on the outside? Each one pumps out 3, right? You're going to have 3,000 sodium ions on the outside. And how many potassium are you going to have on the inside? Right, each pumps in 2 potassium ions, so you're going to have 2,000 potassium ions inside the cell. So I want you to take a look at the difference. Okay, they are all positive charges, okay, but hopefully you can see there are more positive charges on the outside. Okay, so that's why generally you have a membrane potential that's more positive on the outside than the inside. So that's your resting membrane potential, and you'll usually see your membrane potential is going to be, for instance, in your cardiac muscle cells, maybe about minus 90 millivolts. So that minus sign tells you it's more negative inside the cell. Okay, so that's the first concept I want to review. And also the second concept that I want to review is you have these sodium channels, sodium ion channels. Okay, so let's orient ourselves again. This is on the outside, this is on the inside. Okay, so once your sodium ion channels open, how would your sodium flow through? Would it be flowing into the cell or flowing out of the cell? Right. So think of, you pump so many sodiums out of the cell, you don't have a lot of sodium inside the cell. So when they open, especially the channels open, it's going to go down its concentration gradient from high to low. So as a result, when you have sodium channels open, all the sodium rushes back into the cell. And what happens to the membrane potential then? Right? It was negative before, but now because all the sodium ions are coming back, you'll see a lot more positive charges over here. Okay, so that's one concept I want to remind you. And also, when your potassium channels open, here's your potassium channels. Okay, when it opens, how would your potassium ions flow? Would they flow into the cell or out of the cell? Right, you actually set up so many concentration gradient of potassium ion inside the cell, there's very little potassium ion outside. So when your potassium ion channel open, they're going to flow out. Okay? So when potassium flows out, these positive charges leaves, and eventually your membranes inside, especially the membrane potential, are going to return back to negative. Okay? So in today we will also take a look at how some sodium channels opens, and these tends to rush into the cell as well. Okay? Specifically in your cardiac muscle cells. So with this as a review, let's take a look at your cardiac muscle action potential. So action potential is very important. This is how a cell sets up a signal for the following cells to undergo contraction, for instance. So on this side, you will see membrane potentials measured in millivolts, starting from negative values all the way up to positive values. Over here is your timeline. So in your cardiac muscle cell, where resting potential is about minus 90 millivolts. Okay, so this is where you're going to imagine, okay, these are your ATPase pumps, okay, sodium, potassium, ATPase pump. So they're the one generating. So you have so much sodium on the outside, very little sodium on the inside, and a lot of potassium on the inside, very little potassium on the outside. So at the beginning, your resting potential is like this, okay, quite negative inside the cell. Okay, so when an actual potential starts in the cardiac muscle cells, okay, for instance, they happen, we call this when you go from very negative to very positive numbers, that tells you it's a depolarization, okay, because all your sodium ions are now rushing into where there's less of them. Okay, so all of them rush inside and making the inside of the cell more positive. So you'll see that going from negative all the way to positive, and that's called depolarization. So it's because your sodium ions are flowing into the cells when your sodium channels opens up. And these are what we call voltage gated sodium channels. Okay? So they are sensitive to changes in the membrane potentials. Now, so later on, you'll see all these green area is called the depolarization stage. Now, in skeletal muscle, you don't see a long stretch of this plateau, but in the cardiac muscle cells, you do. And this plateau is there because we actually have our, for instance, calcium channels that are opened. So when they're open, okay, then all the calciums are also going to flow into the cell as well. So imagine you have a calcium channel and they also flow into the cell as well. So keeping it positive. And we have a little bit balancing because we have some potassium channels that are open here. And this is just to balance it a little bit. So when your potassium channels opens, all your potassiums are going to go from high to low. So your potassium ions flows out. Okay? Until when you so this is the time from here to here when it's go from depolarization. This is what we call your muscles are contracting. So this is the contraction period of your myocardium. Okay. Okay. Yeah. Oops. Right here. Okay. So now also the cells will return back to normal. So when we undergo the return back to minus 90 millivolts, this is what we call a repolarization because you're going from positive charge inside the cells back to negatively charged inside the cells. So this is because, for instance, your potassium channels, okay, are now open, and they will keep on flowing out of the cell. So positive charge is leaving, making it more negative inside. Okay? So repolarization will let the cells rest back to their resting mode potential. So this whole thing from depolarization all the way to repolarization takes about 0.3 seconds. Now I forgot this question mark for this period is actually a refractory period. Okay. This meaning that when you're undergoing the action potential, so they can't start another action potential. Okay, so this is the time when your cell is undergoing their own actions, things are happening. So only until you're at the end of your refractory period, then you can start another action potential. Okay, so I know this seems a little complex, but hold on to your basic ideas, okay? Specifically knowing when your gradients are set up, for instance, at the beginning, where, yeah, and then you will be able to follow through. Okay? Now, you probably have done this at your cardiologist's office and have your ECG taken. Your ECG is your electrocardiogram. So ECG. So this is an M. So an ECG really measures the overall electrical signals from your heart. So for instance, they will put several different LEDs onto, for instance, onto your arms, legs, as well as chest to measure if your heart is working properly. So when we take a look at how an ECG looks like, hopefully yours will look like this as well. So same thing on the side, it's measuring the millivolts, okay, your changes in your overall membrane potentials, and also here's recording the seconds of it. So let's go through some of these peaks and waves. Yeah. So at time 0, okay. So when they start with the ECGs, what they will see is what we call a P wave. And a P wave is because your atrial is undergoing depolarization. Okay. So that means all your sodiums are rushing in to the cells and it's going from more negative to positive charge inside the cell. Okay. Now this is the P wave, and you will see several different peaks. This bottom one is your Q, the top is R, this is your S. So we call this QRS complex. Okay. And that tells you actually when your ventricles are undergoing depolarization. So we call it ventricular depolarization. Okay. Now, so you probably have a question. Once the atrial depolarize, they also have to relax. So, but your atrial repolarization is masked by the ventricle depolarization. So the ventricular depolarization, the QRS complex, is so huge, it's masking your atrial repolarization. Okay, so you don't really see it over here. And once it's done, you see a T wave over here. Okay. And this is telling you your ventricle is resting. So ventricular repolarization. Okay, and so you'll hopefully get to see some intervals as well as we measure. You can measure the PQ interval. You can take a look at the ST between here and there, the segment, or you can take a look at the Q and T interval. So your cardiologist will take a look at, for instance, how each wave, if they have enlarged or if they are normal, for the intervals, if they're longer or if they're shorter, to determine if your heart is working properly. Now, one example is if you do see a bigger P wave, what do you think it might mean? Right, if it's a larger P wave, because this signals your atrial depolarization. If it's much larger, that might tell you, or you might have your enlargement of your atrium. Okay, so that they can tell and see if your heart is doing all right. Okay, now let's take a look over here on this side. So we're going to follow through little by little and just take a look at how ECG is signaled. Okay, so first, okay, we have our action potential starting from your S signal. So don't forget, this is your autorhythmic fibers. This is your natural pacemaker to set up the tone and pace. So first is your SA node that triggers, and it's at your right atrium and sends out the signal. Once it sends out the signal, this is where your atrium undergo depolarization. Yeah, your fibers are undergoing changes. So they produces the P wave. Okay. So first, you always have to have your action potential first, and then contraction follows. Okay. So that's one idea I want you to be able to remember. So you always have your signal first, and then you have your atrial contractile fibers going off and start with contraction. So that you can see the contraction of the atrial walls here. And when they contract, okay, imagine blood is flowing into the ventricle and filling it up. So the signal next from your nodal system gets to your ventricular part of it. Yeah. So the next thing is for your ventricles to undergo their action potentials. They first undergo depolarization. When they do so, they generate this huge QRS complex. Right? So that is ventricular depolarization. Once you have the signal, this is first. The next is your ventricle contractions. Okay? So when they contract, then they will be able to push out the blood into where they have to go. We'll take a look at where they have to go soon. And then your ventricles are going to relax. Okay? Then it's called the repolarization of your ventricle fibers. Okay? Then you see the T waves. So then relaxation. So always the idea here is you have your action potential first, like in your atrium. Then you have your contractions of the atrium or the atria together. Now the other thing is you probably take a look at this word, atriosystole. This means systole means contraction. Same here. If you see ventricular systole, it also means contraction. And ventricular diastole is relaxation. Okay? And the only thing we didn't really see here is the atrial diastole. Yeah, that means your atrial is undergoing relaxation, but it's masked by the QRS complex over here. Okay? So make sure you can trace through what happens from your atrium all the way to the time when they both relax. Okay? Now, so we saw normal ECGs, okay? And you have the regular P, QRS, and T waves over there. Now, there are times when the beats are out of order. So it's called arrhythmia when you have abnormal rhythm. So you take a look at two types of these abnormal rhythm. First is ventricular tachycardia. This is when your heartbeat is sometimes over 120 beats per minute. Okay. So your heart is working super, super, super hard. And sometimes it's because you might have suffered heart diseases or have recent myocardial infarction. that might causes your heart to work extra hard. Now, on this other hand, you can see a different type of arrhythmia is ventricular fibrillation. This is very deadly, okay, and worse than the tachycardia. And it's because when your heart is undergoing fibrillation, VF or VFib, this means your heart is, your ventricles are quivering. They quiver and they are not contracting rhythmically. So very, very dangerous situation because this may lead to pumping, a cease of pumping. Pumping stops, and that means your blood flow will also decrease to different parts of the bodies. And eventually, if no medical intervention is done, it might lead to death because of the lack of oxygen from the decreasing of blood flow. Okay, so we do have very good treatments. You've probably seen at the malls or at the airport, you have these AEDs. Yeah? So these are automated external defibrillators. So these defibrillator is meant to, for instance, to stop your heart from moving all at the same time and to help them beat more rhythmically. And so, for instance, they encourage people, if you do see someone who's unconscious and need help, first get help, and if you really need to, you might need to actually use the defibrillators on the patients who needs it. Okay. Now, so you can take a look at the ECG animation if you're connected online through the slideshow. So we're going to take a look at what happens in one heartbeat. So we said that, and it's usually in 0.8 seconds. Okay. It takes one heartbeat. And how do we get that 0.8 second? It's actually from our 75 beats per 1 minute. But instead, we change it to 75 beats in 60 seconds. So we want to know how long is one heartbeat. So if you take a division of 60 seconds versus 75 beats, then so you'll be able to get 0.8 second. All right. So let's take a look at the cardiac cycle. So each cardiac cycle is in about 0.8 second, and a lot of things happen in this 0.8 second. So just a reminder, we've seen atrial systole, and this is meaning contraction of your atrium, or both atria, and it also undergoes this relaxation, atrial diastole. Now, your ventricle also will get the signals later to undergo contraction and undergo ventricular diastole, okay, and eventually relaxation period. Okay, so we're going to fill in the details here by looking at this cardiac cycle diagram. First, we're going to focus over here, and then we'll bring in the ECG part as well as the pressure and the volume. Okay, so let's do it slowly. Okay, so phases of your cardiac cycle start from here. Okay, your atrium will contract, and because they first got the signal from your SA nodes, okay, go through a series of nodal system to eventually get to your contractile fibers, specifically your atrial contractile fibers. So that's why then they get the signal to contract. So when they contract, right, they have some blood in here, and the blood is going to flow from your atrium into the ventricle, okay, from top to bottom. So inside you already have maybe 150 mils of it, and you will put in about 25 mils more of the blood into it. So under atrial contraction, you'll see that eventually you'll add up these two volumes all the way up to 130. Okay, over here. Now, so when the blood has filled into the ventricles, so at one moment, when it's all filled, your AV valves and your SL valves are all closed. So we call this the isovolumetric contraction because they have the same volume. Nothing changed. No valves are open right at this point. But they're really technically aren't contracting yet. They're getting ready to do so. And then, okay, your pressure starts because your ventricles are undergoing contraction. So remember, these are when your ventricular contractile fibers got the signal to undergo action potential, and then they undergo contractions. When they contract, they will send out about 70 ml of the blood into where they have to go. If it's from your right ventricle, it goes to your lungs through the pulmonary SL valve. If it's from your left ventricle, it goes out into your aorta and to the rest of the body. Okay, so now the major action occurred. Then it goes through also what we call a relaxation phase, and at this point, all 4 valves are closed. So this is the isovolumetric relaxation. Okay, and until it's ready, ventricles are going to receive the blood from your atria, and the whole cycle starts again. Okay, so far so good. Okay. All right, so let's take a look at your volumes in ventricles. Okay, so we normally have about maybe 105 mil that we say are kept inside your during the atrial contraction. So they will receive 25 mil more that's coming in from your atria. So to reach 130. So that 130 is your end diastolic volume. Okay, and when now your ventricle is working hard, pumping it out. Okay, we have coming back to our end systolic volume. So here is the difference between what you have maximally and what you pumped out. So this is your stroke volume. We'll take a close look at this, as this will relate to your cardiac output. Okay, for each minute. Now let's take a look over here on the pressure, and we'll focus on the pressure on your left ventricular pressure. So follow the blue line. Yeah. So over here we have low pressure, but until and when, for instance, at this moment when all valves are closed, okay, bicuspid valves are closed, okay, the pressure is low, but when your ventricle is ready to pump, shoo, the pressure goes all the way up. Okay, so that's why, and all the way up to 120 milligrams of mercury. So you see, if you take your blood pressure, we're hoping, yeah, this is your systolic blood pressure. And later on, when your ventricle relaxes, then the pressure will drop back down, okay, and repeats again, right? So I hope you can see, yeah, this is that systolic that we see often when you measure blood pressure. Now, so basically, I want you to be able to see that there's a time when your atrial is contracting and it relaxes, and ventricle contracting, systolic, and relax. Okay? And all these comes from signal. So the ECG has to happen first. Okay. Then contractions second. Okay, and plus relaxation. Okay, so make sure you can follow through specifically the phases of the cardiac cycle. Make sure you know each of these phases and what's happening during each of these phases. Okay, now your cardiologist probably will also help you listen to the heart sound. Normally we'll hear just the first 2 sounds. We call it the S1 and the S2. So the first sound is lub, and dub is the second one. So, and Usually you have to imagine if you have a river. Okay, so imagine this is your river and water is flowing through it. Now, if there's no rocks, no tree branches, no nothing, you won't hear a sound. But if you start to put in a tree branch, put in rocks, you probably hear the sound of the river because the water is being disturbed and they make sounds as they reaches these obstacles. Or so same thing. Usually we don't when we don't hear our blood flowing if it's flowing smoothly. But when it's being stopped, for instance, your S1 valve, when you hear the lub, this is actually showing you the closing of your AV valves. Okay, so when your tricuspid valve and your bicuspid valves are closing, you can clearly hear the S1 sound, the lub sound. It's a little bit longer. And when you hear, for instance, the dub sound, this is when your SL valve is closing. Okay, so these are when your aortic and pulmonary valves are closing, and you hear that second shorter dub sound. Now, where your valves are and where you hear the heart sound is a little bit different because the sound of the blood what carries it through where it travels. So the tricuspid valve, even though it's positioned closer to the right side of your rib, between 4th and 5th rib, you'll hear it more towards your left side of your sternum, between your 5th and the 6th. Yeah. And same for your bicuspid valve, you hear it at different places and just a little bit where they travel to. Pulmonary valve and aortic valve will hear it more prominent between your 2nd and 3rd ribs on either side of your sternum. Okay. Now you probably have heard of something called heart murmur. So this is sometimes you have regurgitation of the blood through the valves and you might hear a little noise. And some of these heart murmur probably will go away as children grow up, and some may become more serious if it's because of the heart valves are not working properly. Then they may create more noises or so. Then you should definitely get checked by your doctor. And here is the cardiac cycle animation. So let's take a look at what other factors will help you regulate your heart, especially how your heart beats. So the cardiac output is something we say how much, especially the volume, how much blood is being pumped each minute. So the cardiac output depends on two factors. One is what we call the volume of it, the stroke volume, and also depends on the heart rate. Okay, so this is an O. So stroke volume in a resting adult male, we use it about 70 mils as they each being pumped from the heart, and heart rate will do 75 beats per minute, yeah, per 1 minute. So if you calculate this, okay, I'll wait for you. Bring your calculator. Or, right, use your brain quickly. Right, you have a 0 and you have a 5, right? You have 5250. So you'll have 5,250 mil. Okay, and oh, I forgot to put this is in 1 beat. So we can cancel out the beat, and so we can actually just have mil per 1 minute. So each time you will pump out this many blood. And let's convert this into liter. That may make more sense. So 5.25, if we remove it by 3 points, decimal places, you'll have 5.25 liter per minute. Now, 1 gallon of milk is close to 4 liters. So in each minute, your heart is working very hard. So to pump this much blood. And We also have something called the cardiac reserve. So this is the difference between what we call the maximum versus the minimum cardiac output. Okay. So some people may have a lot more cardiac reserve if they, for instance, if they are trained and have regular exercises done, then they may have, for instance, for athletes, they may have 6 to 7 to 8 times more cardiac reserve than their resting cardiac output. But for patients with heart disease diseases, then they might have very little cardiac output. Oh, sorry, cardiac reserve. Little or no cardiac reserve. Okay, so you got to take very good care of your heart. Yeah. And so let's take a look over here what might affect your cardiac output. So for instance, if we were to increase cardiac output, that means if we want to increase more than what you have, 5250 mil per minute, then we have to work on increasing the stroke volume. This is the amount of blood, for instance, on average for adult male is 70 milliliter. So to how you increase stroke volume sometimes depends on your preload. This is saying how much your heart walls can stretch. Okay. If they can stretch a little bit more, work a little bit harder, they probably can increase the preload. Now also, if your heart is contracting more forcefully, okay, it could be different depending on all different reasons, okay, in your body, then that means your heart works harder, or you want to decrease afterloads, okay, the pressure that goes against it, then eventually you can increase the amount of volume, probably hopefully more than 70 mils each time. You can also increase heart rate by several different ways. Our nervous system is controlling it, our chemicals in our bodies controlling it, as well as other factors. So these are the ones that can ultimately affect it. So what else regulates our heart rate? Besides stroke volume and also the heart is we depend on our nervous system. So we'll take a look at the autonomic as well as the chemical regulations. We have a very important center, our cardiovascular center. Do you remember where it was at? Follow here, right here. What was this place? Right, it is the medulla. Medulla oblongata, okay, of your cardio. There is a cardiovascular center over here, and it receives signals, okay. So signals from where? Signals, for instance, from higher brain centers, from your hypothalamus, limbic system, cortex region, as well as from your sensory receptor. What they want to sense, because, for instance, overall muscle movements sends the message through your proprioceptor that goes to the cardiovascular center. They also monitor blood chemistry through your chemoreceptors, as well as blood pressure through your baroreceptors. So all these informations get sent to your cardiovascular center. Then they decide whether you're going to increase, get your heart ready pumping, or slow it down. If it were to activate it, imagine you're being run over by the wild boar, or hopefully you're not run over, you're running away, then it will signal the sympathetic nervous system, and it's going to activate heart rate, increase heart rate, get everything going, okay, because they will try to depolarize your SA node much faster, okay, and it will work to make sure that your atria and ventricles are contracting a lot, okay. So this will affect the heart rate as well as increase both the heart rate and the stroke volume. If you're relaxed after you're being chased by the wild boar and it's gone. This is to slow things down. So remember our rest and digest versus our fight and flight. Okay, so if it were to go through your vagus nerve, and this is your parasympathetic nervous system, it will slow down the heart rate. It will slow everything down and make sure you can return back to normal. Okay. Now hormones, okay, and cations also regulate. And we'll mention one hormone, for instance, our epinephrine, as well as our norepinephrine, a cousin of it. So they all tend to activate through your sympathetic pathways. So to activate and more calcium release to the heart, as a result, you can increase heart rate because contraction requires calcium. Right? Remember your calciums and your troponin, tropomyosin. Yeah. All right. So regular exercises definitely helps the heart. Okay. And sometimes we have two types of cardiomegaly. This means enlargement of your heart, or sometimes you might hear another word for it is hypertrophy. Okay. Now, if it's because of reasons, natural reason, physiological cardiomegaly usually is because you're trained to do so. Your heart, for instance, will have the same resting cardiac output, but each time they have more stroke volume, meaning each time they pump out more blood. And this is a lot through exercising or so to get the heart slowly acting very efficiently. Now, there's this different from pathological cardiomegaly when you have enlargement of the heart or hypertrophy of the heart because of heart diseases. So then it's a different story, and you have to watch out for those heart if they're working extra hard. For failing hearts, definitely there are help on the way. And for instance, you probably can see over here, this is ventricular assist device. If your ventricles are having a hard time pumping the blood through the system, then the blood is using a device to reroute the blood into the device and with a pump to generate the pumping action into the whole body. And so this might be a temporarily device to happen before a patient gets the real heart transplant. For cardiac transplantation, so we have seen several successful cases over the years, and this is a surgery where you actually have to open the chest wall and you have to sever the superior, inferior vena cava, aorta, and to reconnect everything from the donor's heart to the recipient's heart. And also they have very good survival rates when they keep the donor's heart on a beating cycle, having blood being flushed through it instead of keeping it on ice for several hours. Now, the only thing is recipients, patient who have cardiac transplant probably has to be on immunosuppressant therapy or drugs for a long time, sometime maybe for the rest of their life, to prevent rejection of the heart tissue. Okay. Now, one very interesting thing is when you're a tiny little embryo, probably the first very exciting thing for your parents to hear is your heartbeat. So when can you hear the fetal heartbeat? Let's take a look over here. Okay, so from day 19, you'll start to see the cardiogenic area. These are all developing from the mesoderm, And you take a look at the two ends. You have an arterial end, the venous end of the heart on day 20. So they have these tubings, and eventually they are linked together and form into a heart tubes, and eventually, ultimately, into primitive atrium, primitive ventricles. And by day only 23, everything is developing so quickly. By day 28, at the beginning, your ventricle is here, but they're in the right place by day 28. Your primitive atriums are here, and they've gone to the right place as well. So usually by the end, like 28 days or so, you can probably hear the fetal heartbeat. Okay. And your cardiovascular system, specifically your heart, is one of the first organs to be working for you. Okay. And over here is a diagram of heart disease. Now, can you tell me, based on the look of this artery versus the look of this artery, which one looks blocked? All right, did you find it? This is your normal one, and this is the one with the buildup of the plaque, plus plaque. Okay, so a lot of times we have heard news about plaque formation, forming the atherosclerotic plaque. And so these plaque could be from fatty acids or triglycerides, cholesterol. Okay, so it's very important to keep your body healthy. Of course, you have to have some of these, but of overabundance of them, they tend to have an easily chance to form these plaques. And if they dislodge and start moving to somewhere else until they cannot move anymore, then the patient might have a very serious stroke if it gets to the brain. Now here's also treatments. For instance, if you do have plaque formation, this is an angioplasty plaque type of treatment where they have a catheter that moves into the site where the plaque is. Then the balloon blows up trying to squash the plaques, and the catheter retracts. So hopefully the plaques is not disturbing the blood flow, and you have much better flow and circulation. Now sometimes this might occur again. Then instead of doing the angioplasty, they might put a stent, which is a wiring type of stent. And over here you can see the stent over here trying to maintain the blood vessels and keep blood from flowing through it. Yeah? So usually it's only in one direction. So here's the end of chapter 20. So hope you now realize our heart is working very, very hard for you. So take good care of them. We'll see you in the next time.